So let's get started. So welcome to all the attendees and guest speaker to this sixth Sarcoma educational session in the framework of IMPERAS project. Thank you for all to join us. Please, we encourage to all participants to submit questions or remarks by using the chat box or by using your microphone directly. Please mute your microphone during the presentation to avoid interruption. It is now my pleasure to introduce our first guest speaker for today's session. She is Dr. Alessandra Nascimento, team leader for bone and soft tissue pathology from University Hospital Cleveland Medical Center and associate professor, Case Western Reserve University. She is an international expert well recognized in soft tissue pathology and has contributed to many papers on this area. So we're pretty sure that we will enjoy the presentation of Dr. Alexander. So Dr. Nascimento, please, if you don't mind to share your screen and start the presentation.
Yep. Okay, so can you see my screen?
Yes.
All right. So thank you very, very much for this invitation. I wish I could be in Valencia in person, but we'll try to do the best out of being online. So so good morning, everybody. It's morning here. I guess it's afternoon in Spain. It is my pleasure to be talking to you today, and I'm going to start by presenting a case of a 70-year-old man who presented in December last year with left hip pain. His laboratorial exams were pretty normal, except for some anemia and a mildly elevated PSA. On his physical exam, this man had mildly increased prostate on digital examination with some vague nodularity, had a little bit of a limited range of motion of his left upper extremity, and walked with assistance of a walker, but no definitive mass on palpation. On X-ray, it was he was shown to have a destruction of his acetabulum and vague areas of possible calcifications. He underwent then MRI and PET scans that I'm going to show you now. So on his MRI, he has this mass destroying his acetabulum. It's kind of an infiltrative mass, and there are some hints that there might be some calcifications in here, but it was not definitive. Here again, the same mass on a different view, and his PET scan showing that this mass was pretty hot on PET scan. So he underwent a biopsy, and this was the biopsy I received initially on frozen sections with the question of, is this metastatic prostate cancer? And on frozen section, I looked at this and, evaluated this one biopsy and said, look, you do give me lesional tissue. The cells are epithelioid to spindly. They have very prominent nucleoli. I don't see definitive gland formation, but the prominent nucleoli, of course, could go with prostate carcinoma, but this is a hard call on frozen section. I'd like the chance to do some immunostains on this to confirm the diagnosis, because the surgeons wanted to know at that point, they would just excise the mass if that was the case and fix the bone, versus if they needed to do something different. So they stopped the surgery at that point. And as I said, at the time of frozen section, I just called it a poorly differentiated malignant neoplasm. Although metastatic carcinoma was favored at that point, a sarcoma could not be entirely excluded, and I needed a chance to stain it. So on my permanent sections, I did several immunohistochemical stains, which were all negative. Sent material for actually NGS, which came back with an IDH2 mutation. And given the presence of that possible calcifications, I felt that this fit best with a dedifferentiated chondrosarcoma. This man was shown to have no metastasis and underwent a hemipelvectomy. On the hemipelvectomy, he's had a 6.7 centimeter fleshy tumor, destroying his acetabulum and extending into the ilium, ischial spine, and superior ramus of the pubis, with no involvement of his femur. On cross section, again, the tumor showed quite a fleshy appearance with no necrosis. And on histological examination, obviously the diagnosis then became a little bit more clear, with areas of clear-cut chondroid proliferation juxtaposed to this spindly neoplasm. On higher magnification, here's again the cartilaginous end of the tumor juxtaposed to this nondescript spindly malignant neoplasm. In a higher magnification here, this tumor even showed areas of nesting, again, not different from what we've seen on the biopsy, with very prominent nucleoli, some glassy cytoplasm. And even in areas, there was a suggestion of maybe some osteoid formation, although I'm not entirely convinced, and there are definitely some giant cells scattered throughout. So again, this was a final diagnosis of a dedifferentiated chondrosarcoma measuring 6.7 centimeters on its greatest dimension. In 2021, in March, this man was diagnosed with pulmonary metastasis and started on chemotherapy. He was placed in hospice in July 2021. His pulmonary nodules did not respond, and he died of disease in August this year. So it's a very dramatic, fast course for the disease. And just today, I signed out another case that I want to share, just because it has it overlaps in its presentation with this one. This case that I signed out today is that of a 68-year-old man that was diagnosed with chondrosarcoma grade 2 of 3 of his right femur in 2015. He developed lung metastases that were excised in 2015, 2017, and last year. And this was all done at an outside institution. And now he presented to us here with this new pelvic mass. And here's his pelvic mass on the right side, also measuring about 5 centimeters in greatest dimension, with again areas that are suggestive of calcifications, but that the radiologists weren't convinced were calcifications. And he underwent a biopsy of this mass. And here's the biopsy I received. I received several cores, none of which showed necrosis, but which were all composed of this very granular, these large polygonal cells with very granular cytoplasm, atypical nuclei, kind of pushed towards the side, somewhat a prominent nucleoli, but quite variable. And again, I stained this with pretty much everything we had in the lab. And to be quite honest, there was some staining for chylretenin and inhibin and INSM1, which was sort of weak and multifocal. INI1 showed preserved nuclear positivity, but a host of other stains were all negative. And given his history of chondrosarcoma, I said, well, we have to rule out that this is not a D-diff chondrosarcoma. And lo and behold, molecular just came back just this last night with an IDH2 mutation. And that allowed me then to sign out this case as a D-differentiated chondrosarcoma with unusual granular cell changes or granular cell features. And as I said, this was just signed out this morning, and I believe this man will end up undergoing resection of this mass if this will be possible. I'm sure this will be discussed in tumor board on Monday. So just a few words about dedifferentiated chondrosarcoma. As the definition of chondrosarcoma or dedifferentiated tumors go, this is no different. It's an abrupt transition between a low-grade cartilaginous neoplasm and a high-grade non-cartilaginous producing sarcoma. Tumors arising in the femur, in the pelvis, and humerus are most often the most common sites, followed by the scapula. It happens in about 10 to 15% of central chondrosarcomas, and it's very rare in peripheral chondrosarcomas. The median age of patients at presentation is about 59 years, and there's a slight male predominance. Pain and a palpable mass are usually the presentation, followed by pathological fracture, which is seen in about 20% of these patients. On radiology, usually what we have is areas that look more like a conventional chondrosarcoma juxtaposed to areas that are show a mass that has no matrix formation, no mineralization, and that is obvious in about 50% of CT scans and about 30% of MRIs and X-rays. So here's an example of chondrosarcoma, dedifferentiated chondrosarcoma on radiology, areas that show mineralization, like one can appreciate here, juxtaposed to areas that have a permeative, destructive, non-mineralized appearance. And that is very suggestive of dedifferentiated chondrosarcoma. Again, another feature of this tumor that helps us with the differential is the macroscopic evaluation of these specimens, which usually these tumors show this gray glistening cartilaginous neoplasm juxtaposed to a more fleshy tumor that may have some matrix or not, and may have lots of necrosis. So here are two examples of tumors that are clearly cartilaginous producing, juxtaposed to tumors that are non-cartilaginous producing with this fleshy appearance. And then histologic evaluation, pretty much like we had in the case that the first case I presented, is this juxtaposition of what looks like a cartilaginous neoplasm to a spindly or nondescript high-grade sarcoma. On higher magnification, again, this juxtaposition, this abrupt transition, and the tumors are often nondescript, spindly, just looking like spindle cell, undifferentiated spindle cell sarcoma, or a pleomorphic sarcoma. Sometimes they can be rich in giant cells, like this example here, with lots of giant cells almost mimicking a giant cell tumor. They can have osteoid formation, and obviously the differential comes into play is osteosarcoma. Again, here's some examples of tumors with osteosarcomatous differentiation, tumors with rhabdomyosarcomatous differentiation, some angiosarcoma, and the more common version of just a UPS, an unclassified or undifferentiated pleomorphic sarcoma. So we have some ancillary testing that we can do to try to make the differential, especially with osteosarcoma and with carcinoma. There's one pitfall that I want to make sure I talk about, which is the presence of some cytokeratins that may be expressed by dedifferentiated chondrosarcoma, and that might lead to erroneous diagnosis of carcinoma. So obviously, we're going to take into account what we see on the radiology, what we see in the slides, what we see in the gross of the specimen, but the ultimate diagnosis can be confirmed by the presence of IDH1 or IDH2 mutations in these tumors that are seen in about 50 to 90% of cases, and that varies a little bit in the literature. In my experience, most of the cases I see of dedifferentiated chondrosarcomas, they do have the mutation, and that is very helpful, especially in small biopsies like the second case I just showed you, where this man had a history of chondrosarcoma that was suggestive. It had a typical or unusual pattern with this granular cell change, but the IDH2 mutation helps define the diagnosis. The differential, I mean, the prognosis here is very bad. These patients usually develop lung metastasis, just like other sarcomas. And the 5-year survival rate, again, is a little variable in the literature. But in my experience, these patients have about 2 years usually. And that is usually what we see. These patients basically all die in 2 years. Chemo and radiation do not seem to have big impacts on prognosis. Therefore, surgery with wide negative margins is usually the treatment of choice for these patients when possible. There are some factors that appear to be associated with worse prognosis, and they are tumors over 8 centimeters, tumors that present with pathologic fractures, presence of metastasis at diagnosis, location in the pelvis, and inadequate surgical margins. So here are some references also that talk a little bit about mutations in IDH1 and 2 in these tumors, as well as some larger series of dedifferentiated chondrosarcomas. And with this, I am happy to take any questions, and thank you again for the invitation. I'll just get out of the screen here so I can, I guess, should I stop sharing my screen?
Yes, please.
Okay. All right.
Thank you very much, Alessandra, for this interesting case. Does anyone have any question? I have 2 questions for you.
Okay, go ahead.
I was thinking about the smart CV1 immunostaining in this case, but you have already answered this question because the morphologists remind me at the beginning like rhabdoid tumor or something like this.
Yeah, exactly.
And another important thing that, of course, I wasn't aware, this is granular cell fissure in the differentiated chondrosarcoma.
And this is, this is the first time I actually seen this dedifferentiated chondrosarcoma with this granular cell feature. And I did some looked up some literature. I didn't see anywhere where this was actually described as a conventional or one of the features that we can see in dedifferentiated chondrosarcoma. I don't know if anyone else have seen this. I haven't, and that made it hard because obviously on the biopsy I had no cartilage, and the man's history obviously helped me and kind of gave me the idea of doing the molecular, looking for the IDH mutation, but I wonder if there was no history, no prior history of chondrosarcoma, would I have thought of dedifferentiated chondrosarcoma? So I guess that we learn every day from every case.
Yes. It's just to be keep in mind that when we see rhabdoid or granular cell feature, dedifferentiated chondrosarcoma is a possibility.
Absolutely. And in my experience, they can look pretty much like anything. And this granular cell one just came to reinforce that, that prior idea that I have that these tumors can just look like whatever they want.
And the other question is, what do you think about the immunohistochemistry as a surrogate for IDH alteration?
Yeah, so as far as I know, there's no good IDH immunohistochemistry for dedifferentiated chondrosarcomas or cartilaginous tumors in general. The only immunohistochemistry that I am aware of for IDH are the ones used in gliomas, and they pick up a different mutation. So I don't think they're useful for the diagnosis of chondrosarc.
Okay. So any other question? Brendan, Mari Carmen, any other participant? Do you have additional questions or remarks?
Actually, I have a quick question, if I may. Sure. Dr. Nascimento is obviously recognized
Alessandra, please.
Internationally recognized.
It makes me feel old.
You're well established for having characterized the epithelioid variant in myxofibrosarcoma as well. And I'm just wondering, do you think that the epithelioid morphology here might have anything to do with the really, really aggressive course that you saw in the first case, or is it just happenstance? Because obviously, you know, many epithelioid tumors have a propensity for metastasis. And
yeah, that's a really interesting question. And you know, and I'm going to have a disappointing answer is I don't know, but you may have a very good point there. That would be an interesting thing to look at. Absolutely.
I'd love to read your series on it down the road.
Oh, maybe we'll do our series. I don't think I have enough of those.
Okay, any further questions? El que quiera hacer una pregunta en español también, no problem.
Well, I do speak Portuguese, but then someone will have to translate the Spanish.
Yeah,
I can do Portuguese, but
I will try. So if no, thank you very much, Alessandra.
Thank you. I'm going to mute myself so I don't.
Okay, so now I am glad to introduce our second speaker, Dr. Brendan Dickson, pathologist in the Department of Pathology of Laboratory Medicine and Mount Sinai Hospital and associated professor in the Department of Laboratory Medicine and Pathobiology at the University of Toronto in Toronto, Ontario, Canada. He is a very well-recognized expert in soft tissue sarcoma and soft tissue pathology, and also has contributed to many papers on this area. So Brenda, thank you very much. If you don't mind, you can start your presentation.
Thanks very much. So you should all be able to see my screen, I hope, at this point.
Yes, yes.
Excellent.
We can see you and your screen.
Perfect. So it's an absolute privilege to be here today amongst all of these illustrious speakers, not only today, but also in the course of this entire series. And no doubt a great advantage of having this wonderful technology that allows us to beam in from throughout the world at a moment like this. And related to that, you know, I wanted to try to tie in a case that emphasizes not only the role of technology and how it allows us to do our job, but also how it relates to our broader communication with colleagues. And so the case that I'm going to present today is actually one that was shared with me with a colleague, a surgical oncologist, in fact, in Malaysia. So one day I came into work and found an email with a question about a case. And I'm going to walk through this case with you. And so the initial volley of images that you're going to see are actually shared with me, and we'll work through this case together. So this is a case of a 30-year-old woman who was previously well and presented was identified as having a mass incidentally identified in the course of a C-section. And so on imaging here, you can see that we have a large retroperitoneal mass extending down into the pelvis. And on imaging, obviously, there's heterogeneity to this mass and a prominent vasculature. And the other thing that you might appreciate, albeit somewhat subtle on this image, is that there's somewhat of an asymmetry here in the pelvis. And when we look at another image, you can see it perhaps a little bit better exemplified here, but obviously diffuse thickening throughout the subcutaneous tissues. So the patient was evaluated and found to have this asymmetry, not just on imaging, but when questioned by the clinicians, noted to have a 10-year history of this mass. And in terms of the retroperitoneal mass, a biopsy was undertaken in Malaysia, and it was evaluated histologically and found to show mature adipose tissue. And they submitted it for FISH testing and found that there was no evidence of MTM2 amplification. And it was signed out with a differential there as between a lipoma and a well-differentiated liposarcoma. And as all of you are aware, the idea or concept of a retroperitoneal lipoma is relatively controversial. And it was only in the last decade or so that we came to realize that these are actually true. Up to this point, most people thought that they were actually just well-differentiated liposarcomas. And so even though this has only been really well characterized in the last decade or so, there, even in the Spanish literature, as early as this year, remains considerable controversy about this entity. And even in my own institution, my surgical oncologists, when I sign out something as a retroperitoneal lipoma, they do continue to follow these patients. And from time to time, will biopsy again for fear that they might have missed something on sampling. So it's no surprise that in Malaysia, the patient went on to have what is obviously quite a radical resection, given a concern there that the patient may in fact have a well-differentiated lipoma like liposarcoma. And you can see, obviously, this is quite a morbid procedure and involved resection of this multilobulated mass in 2 parts. And when this specimen was evaluated, again, all up to this point in Malaysia, it was found to be relatively bland, and FISH was done, repeated again, and found to be non-amplified for MDM2. And so the tumor was classified as a lipoma. And this is kind of where I came into the picture. So the patient has this large retroperitoneal mass that was resected and found to be a lipoma, but there remains this buttock lesion. And so the surgical oncologist contacted me at this point and wanted to know, A, should this be biopsied? And B, given the anticipated morbidity of resecting the soft tissue mass of the thigh, could the patient be managed conservatively? And so to this, of course, as a pathologist, I replied, I'm more than happy to offer an opinion, but it would be very helpful from my perspective to actually have some slides to have a more objective idea of the pathology. And so here you can see, again, all sent to me from Malaysia, we've got a fatty tumor with a low magnification, minor variability in the size and shape of the adipocytes. At higher magnification, you can appreciate that we have some variability in vasculature as well. We have some ectatic vessels. We have some more thick-walled vessels. And again, minor variability in the size and shape of the cells. At higher magnification, we see that we've got some thick-walled muscular vessels and a little bit of variability in the morphology now, where we've got some eosinophilic cells with multivaculated cytoplasm, but by and large, nothing really morphologically concerning. And again, just a high magnification picture just to show you again the relative homogeneity of the nuclei. So the FISH image, a representative FISH image, was sent to me. And again, there was no evidence here of MDM2 amplification. You could see that the centromeric probe relative to the MDM2 probe is equivalent. And so I can understand why this was called a lipoma in Malaysia. And really, the differential being as well a well-differentiated liposarcoma. But for me, morphologically, I was quite suspicious that this, in fact, represented an angiomyolipoma, a so-called fat predominant variant. And of course, the differential would also include things like a hybrinoma and an intramuscular hemangioma, which often has an obscuring fatty component. And at this point, I asked permission to share the radiologic images with one of my dedicated MSK radiologists here. And to the differential, he added the possibility of a myelolipoma. But we didn't have a really satisfying diagnosis. And so at this point, I thought it would be helpful to actually have the physical material to evaluate. And they were very kind and obliged and sent me some representative unstained slides. And so here now we have one of the unstained slides I stained in my lab here. And you can see that we have, again, a variably prominent vasculature with vessels that are somewhat thickened in areas, and elsewhere they're more ectatic and thin-walled with a variably thickened wall. There's minimal variability in, again, the size and shape of the adipocytes. But you can appreciate that even in some of the vessels, the thickness of the wall is asymmetrical, and you can almost appreciate at this intermediate magnification somewhat of an epithelioid to spindle cell morphology in the wall. And elsewhere, bands along the fibrous septae of these spindle cells with, again, minimal atypia, but not something that you would typically expect to encounter in a lipoma. And of course, when I did HMB45 staining, as well as melanate to a lesser extent, we have staining of these cells for HMB45. So of course, this supports my suspicion that this is an angiomyolipoma, the so-called fat predominant variant. And while they had sent me the slides from Malaysia of the primary tumor, I'd also suggested that they go ahead and biopsy that second lesion, and they included slides of that specimen now, which I will show you. And so here's a needle core biopsy of the thigh mass, and you can see that it has somewhat different morphology. At low magnification, you can appreciate that we have these really, really large, prominent, thick-walled vessels, and then a background of fibrous tissue and fat. And the fibrous tissue and fat have a very irregular relationship to one another. And this doesn't look like a lipoma per se. It's not pushing in its margins. It's sort of permeating through this irregular collagenous stroma, and it gives you almost a hematomatous appearance, an irregular morphology, rather than something that really looks neoplastic per se. Here, a higher magnification of the fatty component, just to show you that there's relative monomorphism amongst the fat, and nothing to suggest anything untoward here or malignant. And when I looked at this, obviously this is benign adipose tissue, and I was suspicious that this may represent hemihypertrophy due to segmental lipomatosis, or just lipomatosis. And obviously lipoma would be in the differential. And why is this important? Well, when going to the literature at the time and trying to put things together, I found a single case report dating back to the mid-80s of diffuse lipomatosis occurring in a patient with tuberous sclerosis. And in fact, in the interval, there were a few other case reports just suggesting this. And in putting this talk together, I see just this fall or summer, late summer, a small case series came out to this point. Again, so lipomatosis arising in the context of tuberous sclerosis. And so with this information, I went back to my colleague, the surgical oncologist in Malaysia, and I said, I'm really concerned that this patient may actually have an underlying genetic predisposition, something like tuberous sclerosis, and I'd recommend evaluating the patient for any stigmata to this end. And he wrote back and said that because of the COVID situation, obviously he couldn't see the patient, but she was an extremely bright and well-informed patient, and she took some pictures of some skin lesions, which he forwarded me. And so the first lesion here, you can see that we have this hypopigmented macule of the skin. Many of you will recognize this as a so-called ash leaf lesion. The patient's toes had a number of interesting findings. You can see that we have these lesions here, these ungual fibromas, if you will, that obviously involve the germinal matrix of the nail and cause dystrophy in the subsequent nail, kind of like a glacier receding and scalloping away the earth from the surface. So we have these ungual fibromas here and again here, and then on the other toe as well, other foot rather. And the patient on the shoulder also had this sort of cobblestone appearance of this hyperpigmented lesion with obviously a cobblestone-like appearance. And this, of course, is a so-called Chagrin's patch. So putting all of these things together on a clinical basis, this patient obviously fulfills the criteria for tuberous sclerosis and at the moment has molecular confirmation pending. So why is this important? Well, obviously, it's imperative for patients with tuberous sclerosis to be followed appropriately because these patients require multidisciplinary care. They have a predisposition to a number of lesions, both benign and malignant. And of course, also for this patient who had, of course, had this lesion initially identified in the course of a second pregnancy, it's important to have genetic counseling for the risk for her offspring. And so this case dovetails quite nicely into a couple of other cases that I've very recently had that I'd like to discuss in relation to this. So the second patient that I'd like to discuss presented with a mass that was identified on surveillance imaging. She had had a history of Lyomyosarcoma diagnosed 3 years ago and was being followed for that when a lesion involving the small bowel and a second involving the large bowel was identified. And so this patient was being evaluated at our center, and so I was asked to review the resection specimen, which had been called Metastatic Lyomyosarcoma. And I can see why that pathologist called this Lyomyosarcoma. We've got a spindle cell neoplasm here with a fascicular pattern. On higher magnification, we have some minor pleomorphism. We have conspicuous mitotic activity. But this tumor also had another area that was morphologically somewhat different. So we can see that in addition to these prototypic areas here that are reminiscent of smooth muscle, we also have these nests of epithelioid cells, some with clear cytoplasm, some with these retraction artifact and multinucleation and pleomorphism. Again, exemplified here at higher magnification and as well mitotic activity. And so I was obviously suspicious that this could be something not just a Lyomyosarcoma, but obviously a malignant Pacoma. And to that end, I requested a block from the original center. And this is again just showing the interface between the area that looks very much like smooth muscle and the more epithelioid area. And you can see that the smooth muscle area is or more diffusely positive for desmin, diffusely positive for smooth muscle actin, and positive for HCl-desmon, whereas the area that looks more epithelioid is diffusely positive for melanase, and to a lesser extent, HMB45. So in this case, I reclassified the tumor as a malignant Pacoma, and I don't take changing other people's diagnoses lightly. And I sent the case off for molecular confirmation just to make absolutely certain that this was a Pacoma. And indeed, you can see here that the patient has a TSC2 mutation. It has a rare variant that had only been to date reported in a single patient. And this, of course, led to a premature stop codon and was pathologic in origin. And as we just heard with the last case, as happenstance would be, many of these cases come in rapid succession. So this is a case I actually signed out last week. And this is another patient, and also likewise another 55-year-old woman. But in this case, she had a known history of tuberous sclerosis and had 7 years ago a hysterectomy due to so-called symptomatic fibroids, where she was diagnosed with a stump. And here now presents with an obstruction. And to evaluate the obstruction, a needle core biopsy was done as a mass was identified on imaging, and this was shared with me in consultation. You can see here on intermediate magnification, a spindled epithelioid cell neoplasm with this anastomosing pattern and prominent vessels set in this hyalinized stroma. On higher magnification, the mass has minor variability in size and shape, but we do have mitotic activity here and there. Again, a higher magnification just highlighting the macronucleoli and relative epithelioid appearance of the mass. And HMB45 staining here shows the tumor's positive for HMB45, and to a lesser extent had melanase staining as well. And so I agreed with the referred diagnosis of this needle core biopsy that this was indeed a malignant Pacoma. And I then sought to obtain the prior stump or smooth muscle tumor of uncertain malignant potential that the patient had had 7 years earlier. And here it is. And you can see that morphologically it looks very similar. We have these anastomosing bands of hyalinized stroma with prominent vessels. And on intermediate magnification and higher magnification, we've got a population of spindled epithelioid cells with macronucleoli that are not dissimilar from that which we saw on the metastasis. So with the benefit of retrospective review, I wasn't involved in the initial hysterectomy, but with the benefit of all of this knowledge and with the benefit of the clinical information that wasn't available to the original pathologist, it's clear that the original uterus was also a malignant Pacoma. And why is this important? Well, from a diagnostic perspective, obviously we always as pathologists want to get the diagnosis correct, but from a management perspective, we know that TSC1 and TSC2 mutations result in aberrant activity and signaling through the mTOR pathway. And why is this important? Well, because there's also clinically available or clinically accessible mTOR inhibitors. And so with the diagnosis of a malignant Pacoma, these patients do avail themselves now to a medical therapy, which shows quite promising results when it comes to objective response to treatment. So the vast majority of these patients will show a response to an mTOR inhibitor. And there's early evidence now just coming out of a very recent prospective study suggesting that this might actually also relate to the underlying molecular event. And that is tumors with a TSC2 mutation may show a better response than those with TSC1. And this obviously doesn't include the minority of Pacomas that have TFE3 fusions. Obviously, they wouldn't be predicted to respond to this therapy. And this, again, is just restricted to those with the TSC1 and TSC2 that I'm talking about. So just to summarize, it's very, very important for clinicians and pathologists alike to identify patients with tuberous sclerosis, because this obviously is a multi-system disease, and these patients benefit from multidisciplinary care. And likewise, there's an important role, not just for the patients, but their progeny as well when it comes to their management. And related to this, while the vast majority of Pacomas are sporadic, a subset do occur in this context, as we've just seen, but it's important that pathologists recognize Pacomas and get the diagnosis right. And of course, this can be challenging due to the rarity of these tumors. It can be challenging due to the fact that these tumors have a broad spectrum of morphologies, and indeed their immunophenotypes sometimes are quite challenging. They may not have diffuse staining for melanocytic markers. So it's very important that we have a low threshold for thinking about this in our differential when encountering these tumors. And it's important not just for a diagnosis, but also for therapeutic reasons as well, as we've seen. And my timer tells me that I've got to wrap things up, but just to close with, I guess the point of underscoring the need for a subspecialty-based practice when it comes to evaluating these tumors. Obviously, the more volume that we see as pathologists and clinicians, it leads to a more refined diagnostic and therapeutic approach that these patients with rare tumors do benefit from. And so with that, I'd just like to very, very quickly acknowledge my colleague, the surgical oncologist, Dr. Faisham in Malaysia, who shared the main case with me that I'm now sharing with you. My radiologist colleague here in Toronto, who evaluated the radiology here for a second perspective, a radiologic perspective, and the technical support I have from my lab here. So thank you very much. And with that, I'd like to entertain any questions.
Thank you very much, Brendan, for this nice case. I think that this represents a very important of the multidisciplinary treatment working in not only in soft tissue pathology, in the whole specialty. So does anyone have a question or remark to Dr. Brendan? Dr. Brenda, do you think that maybe some Lyomyosarcoma, uterine Lyomyosarcoma, so I mean in the past, may represent Pacoma or myofibroblastic tumor or something like this, no?
Absolutely. Yeah, that's an excellent question. This whole area, actually, I mean, when you go to the literature, it's a lot of fun because this is highly controversial. So I believe it's Dr. De Silva in Texas who came out on one side saying that epithelioid smooth muscle tumors in the uterus are just leiomyomas or leiomyosarcomas, and you can have aberrant melanocytic differentiation in response to early reports suggesting that these were Pacomas. And so there was, and this back and forth continues to play out in the literature. Can you have aberrant melanocytic differentiation in smooth muscle tumors of the uterus, or are these in fact Pacomas? And the right answer is we don't know until we do the molecular. Obviously, leiomyosarcomas have a very different pathogenesis than Pacomas. And if we have a TSC1 mutation or a TSC2 mutation or a TFE3 fusion, we know clearly that we're dealing with a Pacoma. And really, we're now only starting to see with the widespread application of next generation sequencing, these papers are starting to come out. And I'm sure, I'm fully confident that you're going to be having a response to your question in the affirmative that yes, many of these in fact are Pacomas. And I suspect even further that a lot of these tumors that look like leiomyosarcomas, in fact, without the epithelioid morphology, might in fact also be Pacomas. And so when you go back and look at the morphology, it may not always be predictive of whether or not it's going to be a Pacoma. Sometimes that morphology comes out on a metastasis. Sometimes it's missed as a function of sampling. It can be, very, very focal. And so absolutely, I think that, more and more as molecular creeps into our day-to-day practice, we're going to be seeing a lot more of these cases that in the past would have just been called leiomyosarcoma.
And another question, that like solitary fibroid tumor, there is a problem between this terminology of benign, long ray, high ray. so in Pacoma is something similar. So some Pacoma or angioleiomyoma have a benign behavior, but there is well-established the criteria to diagnose a case as a malignant Pacoma?
Yes.
You have to see the metastasis, or there is?
Yeah. So that's a great question, and so there's the answer, of course, is always more complicated. The criteria for diagnosing a malignant Pacoma in the uterus is somewhat different than in the soft tissue. And in the uterus, you're going to look at the size, so over 5 centimeters, the presence of mitotic activity, the presence of nuclear pleomorphism, the presence of LVI, and the presence of necrosis. And that combination will, based on a score, much akin to the prognostic index that Liz D'Amico developed for SFTs, will predict whether or not they should be classified as benign, of intermediate biologic potential, or outright malignant. And so the paper that I'm alluding to is by Esther Olivia at Mass Gen, and she has a lovely paper that details exactly that, looking at each of the criteria and how to apply them to uterine tumors. And I believe Andrew Fulp in the soft tissue has the equivalent as well. So you're absolutely right. The biologic potential of these tumors is difficult to predict. And related to that, you also squeezed in leiomyoma. In the uterus, obviously in the gynae world, we have lots of different criteria for smooth muscle tumors, so-called benign metastasizing, diffuse leiomyomatosis, all of these entities. And I think that now the literature is starting to suggest, and many people are starting to believe, that in fact, these might have just been well-differentiated leiomyosarcomas for which the morphology doesn't predict the biologic potential. And so there's an excellent study out at the French sarcoma group looking at predicting the biologic potential of smooth muscle tumors of uterus based on a molecular profiling assay related to the GenSarc study. And so I think more and more and more, we're going to be seeing this convergence of molecular in our day-to-day practice to help us predict the biologic potential of these tumors, the diagnosis of these tumors, as well as identifying therapeutic targets. So I think it's a very exciting time for us to be pathologists. And at the same time, I don't think we're going to be losing our role to machine learning or artificial intelligence anytime soon, because it really requires this synthesis of all of these different pieces of information.
Okay, thank you very much. And any further questions or remarks? Please, does anyone have any question? So thank you very much, Brendan, for your nice case and for your presentation. And let me now try to share my screen because I have the presentation of Dr. Abbas, but they say that I cannot minimize the Zoom during the record. Yes, wait a moment. So now is the time for our next speaker, that is Dr. Ahmad Ahmed. He's professor at the University Hospital Erlangen from Germany, and also for Comprehensive Cancer Center, Erlangen, Germany. Sorry, wait a moment, please. I'm trying to share. Many pathology papers in International Pathology Journal. I cannot find. Sorry. Sorry, I'm trying to share the screen. I'm looking for the presentation, but I cannot reduce the Zoom. So now is the time for our next speaker, that is Dr. Ahmad Ahmed. He's professor at the University Hospital Erlangen from Germany, and also for Comprehensive Cancer Center, Erlangen, Germany. We have contribution in sarcoma research and many pathology papers in International Pathology Journal, and he also member of many editorial board of important international journal. So Alba, thank you very much to be part of this session. And now, when you give your slide, you can start your presentation.
Thank you, Isidro, for the kind invitation and the introduction to this educational session on sarcoma. For me, it is the first time to contribute to this. And as I told you, I have selected one case just to highlight some of the new features of classification in some rare entities that we still may have under-recognized. So this case indeed is not a consult case, though it is the only in-house or routine case we received a couple of months ago from our pediatric oncology department. The patient is a girl, all 12 years or 20 years old, and she presented with central symptoms with some convulsion-like episodes, and then imaging was done, and multiple cerebral metastases or metastasis suspicious lesions were seen. It's very unusual associated cystic hemorrhagic component on imaging. We will see this later, and at the same time, an infraclavicular chest wall mass was seen, which is most likely interpreted as the primary neoplasm. This is the imaging of the cranium, and we see these metastasis suspicious partial necrotic lesions associated with this extensive bleeding with some fluid levels as we see here and there. So this is very unusual in this age. I do not like to go into details of differential diagnosis on imaging of such cases, but usually we see something like this, mainly maybe in choriocarcinoma and angiosarcoma, of course, but the age is not that typical of angiosarcoma, and also there was no evidence of a germ cell malignancy. So these are the multiple lesions. Then the chest CT showed a few peripheral, mainly lung nodules consistent with metastasis, and this infraclavicular multinodular cutaneous contrast enhancing mass at the periphery, which was PET positive, as we see here. So really there is no any genuine differential diagnosis before that. Then they decided to obtain radiology guided biopsies or co-needle biopsies, and we have the multiple biopsies here obtained by the pediatric radiologist, and we see very extensive hemorrhage as well. So this is in line, of course, with the cerebral metastasis. However, very little neoplastic tissue was seen here, a small fragment there, here and there. And if you look at hair magnification, you see there is some tendency.
Lo siento, Cleo, pero no puedo hacer nada. Yo lo tengo al 100%. Ya enviaré la charla y el que la quiera ver que la vaya en la web. No puedo hacer otra cosa. Más del 100 no puedo subir el ordenador.
Specific in the appearance, in the higher magnification, and everywhere these fragments look like this, relatively homomorphic, elongated or ovoid spindle to epithelioid cells, really nondescript histology, no architectural specificity, and a few mitosis were
So I am very sorry, but I don't know what happened that many people have told me that they cannot hear the presentation from Dr. Abata-Jaime. I don't know if it is a problem of a record or something like this. I am very sorry for that, but no problem. We will upload the presentation in the IMPERAS website, and otherwise, if anyone want to hear the presentation, we may send you by WeTransfer. Sorry for this inconvenience, but there is a problem with the computer that I cannot turn out the volume higher than 100%. Sorry to this problem. So I don't know if Ava is here, connected just to replace any answer, so I cannot see Ava's. So as I told you, if anyone have want the presentation, I will be more than happy to send you by WeTransfer, okay? I'm sorry for this inconvenience. So our last speaker is Dr. Harry Sawan. He's a soft tissue pathology and gastrointestinal pathology from Pathology Department of Belleville University Hospitalet de Llobregat, Barcelona. He is a well-recognized expertise in soft tissue pathology, and he will present, I'm very pretty sure, an interesting case. So Harry, thank you very much to be part of this session. If you don't mind, you may share.
Thank you for your invitation. Can you hear me? And can you hear me? And can also you see me? Okay. Okay. I wish I'm going to be luckier than previous speaker. For me, almost have been in a hurry during last hour because internet fell down in my hospital, so I have to came quickly at home, because if not, it's going to be impossible to present. So I'm going to try to share my presentation. Can you see?
Yes.
Can you see the presentation?
Yes.
Okay.
Could you? Perfect.
Okay. So, well, my case is about a man 63 years old that was a smoker with phenolic habit, cocaine and cannabis consumer. In his medical history, I want to highlight high blood pressure, dyslipidemia, diabetes mellitus, and gout. Well, this picture is just to say that he was a cook. In 2000, he was operated by aesthetic abdominoplasty, and 6 years later, he began to notice small and painless nodules in the abdominal wall, growing and merging into a big tumor, but he never sought consultation. More recently, in November 2020, he came to the hospital with a cough, hemoptysis, and fever. He had no lost weight and didn't have asthenia, anorexia, or chest pain. The PET scan showed a few small nodules of a ground glass appearance in the lungs, interpreted as inflammatory. And in the abdominal cavity, they saw a big subcutaneous abdominal mass, ametabolic, suspected to be hemorrhagic, some kind of hematoma. And with this hypermetabolic area in the posterior part of the lesion, also suspected to be inflammatory or perhaps abscessed. The abdominal CT scan showed the same big tumor in the abdominal area, also with a hemorrhagic appearance. Well, to study lung nodules, they indicated a bronchoscopy. It was normal, but also they took samples for cytology and microbiology. Cytology results were negative for malignant cells, and the cultures were negative for bacteria and fungus. The abdominal mass was drained and cytologic material was examined. It showed a serohematic background with cellular debris, badly preserved macrophages, lymphocytes, neutrophils, and all consistent with benign cytology. Well, so at this point, we had a man with cough, hemoptysis, long nodules, and a big abdominal mass, and also with no results, no positive results. So clinicians decided to remove the abdominal mass. These are only fragments of a big pseudocyst, measuring 22 by 18 by 10.5 centimeters. You can see this irregular and hemorrhagic material on the inside. Also, you see this capsule, this white capsule of fibrous aspect with this hemorrhagic material on the inside and some adipose tissue on the outside in some parts. Also, a lot of multiple irregular and hemorrhagic fragments of a spongy appearance were submitted with this pseudocyst. This is the aspect of these spongy fragments. You can see this fibrinohematic background with a few inflammatory cells, like you expect in an hematoma. Also, this fibrinohematic material inside and this fibrous wall on the outside. This is another aspect of the wall with this hemorrhagic material, a fibroinflammatory wall, and adipose tissue on the outside. At higher magnification, you can see these foamy macrophages, some inflammatory cells, also hemosiderin deposition in here. In some areas, we saw inflammatory infiltration by neutrophils. And you can see this cholesterol cleft deposition in the wall, some of them surrounded by foamy macrophages. All of this you expect in a hematoma. Also, there was a chronic inflammatory infiltration with plasma cells and lymphocytes. Well, in some areas, some areas try to endothelialize. You can see here these flat cells over the fibrous wall, and also in here, trying to form round structures. And these cells were positive for CD31, so they were endothelial cells, trying to endothelialize and organizing this thrombotic material. Well, endothelial cells began to make small vascular channels, some of them surrounded by neutrophils. And these vascular channels became more complex and abundant, penetrating the fibrous wall. At higher magnification, you can see this complex vascular proliferation penetrating the wall. Some of the endothelial cells became larger and began to aggregate and form these small round nodules. In these solid small nodules, we saw this vesicular nuclei, and we identified some mitotic figures. As you can expect, this proliferation was positive for endothelial markers, CD31 and ERG, and also for cytokeratin. You know that endothelial cells may express sometimes this marker. Well, at this moment, we began to think about an atypical vascular proliferation or perhaps an angiosarcoma. But also we were worried about if this was the only atypical area in that big tumor. So we went back to the gross specimen, trying to find any different area. So slicing more and more of the material, we found this whitish zone with some necrotic areas. This whitish zone was near the fibrous capsule, measuring 7 centimeters. Well, microscopically, we saw these tumor cells growing in papillary projections in solid areas with irregular spaces. And in solid areas, you can see these large cells with large and vesicular nuclei, this prominent and central nucleoli, and an abundant cytoplasm, giving it an epithelioid appearance. Also, the mitotic index was high, and vascular markers were positive. Also, CD34, although these markers stained fewer cells. Cytokeratin in this solid area was negative, and the Ki67 proliferative index was high, almost 40% of the cells. So finally, we made the diagnosis of epithelioid angiosarcoma on a chronic hematoma. Well, posteriorly, the cranial CT scan showed several intracranial nodules, as you can see here, compatible with metastasis, and also lung nodules were interpreted as a lung metastasis. Also, the ground glass appearance in the lung nodules was compatible with metastasis of angiosarcoma. And finally, this was on December 2020. So patient became infected with SARS-CoV-2 and finally died of COVID pneumonia. Well, this entity, the angiosarcoma on a chronic hematoma, has been reported in the literature, usually as isolated cases, like here, but also in this brief series of cases. This article, in this article, the authors collected 5 cases of the institution and also 4 additional ones from the literature. And they said that for an angiosarcoma, to prove that an angiosarcoma has developed on a previous hematoma, they require 2 conditions. One is that the time between the onset of the hematoma and the diagnosis of angiosarcoma has to be at a minimum of 1 year or more, just to prove that hematoma was previous to angiosarcoma. And the second is that you have to see a fibrous wall to prove that it's a chronic process. Our case fits well with these 2 conditions. The time between the beginning of the hematoma and the diagnosis of angiosarcoma was 14 years. And we saw a fibrous capsule, as you have seen. Well, this entity, this angiosarcoma is a disease of adults, mostly men. There is only 1 female. And usually the tumor is of a big size. Almost all cases have 10 centimeters or more. And the vascular proliferation usually invades all the thickness of the wall, affecting the surgical margin, all except 1. And this patient in this series had no metastasis and was alive with no evidence of disease 18 months later, I mean, after the diagnosis. So the authors give importance to this point, to have a free surgical margin. Well, they also try to explain why an angiosarcoma has developed on a chronic hematoma and give 2 possible explanations. One is that fibrin, and specifically thrombin, is a potent thrombin of the inside of the tumor, is a potent stimulus for endothelial proliferation, similar to an organizing thrombi, as I tried to show in this picture. And secondly, the effect of chronic inflammation on the induction of cell proliferation is the second, as similar to what occurs with chronic gastritis that sometimes is related to gastric cancer. Well, among genetic alterations that has been found in angiosarcomas, perhaps the most prevalent one, the most consistent one, is MYC amplification and c-MYC overexpression in secondary angiosarcomas, I mean radiation-induced or lymphedema associated. But also there are several other mutations that have been found in small percentages of angiosarcomas, like IDR mutations in primary breast angiosarcomas, or these mutations, TP53, POD1, or PTP-RB mutations in head and neck angiosarcomas in the elderly. And well, now I have a question for the audience, because organizers asked me to put some questions. So this is my question for the audience. Which of the following alterations do you think have been found in angiosarcomas arising on a chronic hematoma? Can you hear me?
Yes, but I don't know if I can answer you.
But I cannot see the answers. Just if it's P53 overexpression mutation or c-MYC overexpression, both markers or neither?
There is an answer in the chat box, Javi. Neither.
Okay. Well, it's like a joke. Well, if you want, I can go on.
Well,
okay. So these were the results in our case, and also in 3 of the 5 cases of the article I talked about. I mean, c-MYC immune expression was positive in most of the cells, and P53 was have a wild-type pattern of expression. So we saw c-MYC expression like similar that we see in secondary angiosarcomas. Well, to finish and take home messages, when dealing with an hematoma, especially a long-standing hematoma, be aware that an angiosarcoma may develop on it. So slice all the material looking for white areas different from the hemorrhagic ones. Look especially at the periphery of the hematoma, the junction between the fibrous wall and the hemorrhagic material, because that is the area where endothelial cells proliferate. Expect an epithelioid morphology of angiosarcoma. Evaluate the surgical margin as an important prognostic factor, and this angiosarcoma may express c-MYC. Well, this is not very sure, this is not demonstrated for all cases, of course, but yeah, it's done in 4 cases. And that's all.
thank you very much, Javi, for this interesting case. There is any question? So you can see the chat box, Javi?
Yes.
Yeah?
Yes, no.
There is a comment from Sylvia and a question from Carlos Antonja.
So it's coming from the bone marrow. The question is that, well, thank you, Sylvia, thank you very much. And for Carlos, are tumor cells coming from the bone marrow? Well, which tumor cells? Tumor cells that inside the hematoma?
The angiosarcoma cells. My question is, are these circulating endothelial cells that populate the hematoma and then transform into malignant cells?
Well, I cannot demonstrate exactly, but I suppose not. I suppose the endothelial cells began to grow inside the hematoma by the explanations I made. I mean, the endothelial cells perhaps just trying to organize the hematoma are appearing, these endothelial cells in the hematoma, and then proliferating by the chronic inflammatory induction.
There is another question.
If I answer your question. No, then the question of Sergio Sanchez Sosa, if MYC was done by fish, no, the answer is no. No, it was done only for immunohistochemistry.
Any further question or remarks?
No.
Alessandra, Brendan, Enrique, Any other questions? Cleo, Mari? No? Okay, thank you very much, Javi, for your night presentation and for your night case. Thank you very much to all the attendees. Thank you to Alessandra, to Brendan, to Javi, to all the attendees. And thank you also to the technology for the valuable, helpful in this session. That was very helpful, the technology. So I'm sorry to couldn't be able to share the recorder for Dr. Abada Ahmed. I had the opportunity to see the case, and it's a very interesting case. So I will send to you the presentation if you want, or you can see the presentation in the IMPERAS website later. So thank you very much to all. I'm hopeful to see you in the next session. The next session will be peculiar because the speakers are coming from Sydney, Australia. So we should start the session in the morning. I will inform you, keep you informed about the exactly time because it's depending of the speaker of Australia. So hope to see you soon, and thank you very much to join this session. Bye-bye. Ciao.
Chao Isidro y gracias por todo.